Hello, my name is Ryan Dones. I am a student pharmacist, and today we will be discussing diabetes. So, looking at some quick facts, roughly 96 million Americans have prediabetes, and 34 million have type 2 diabetes. And it actually falls number 7 in the leading causes of death in the United States. And at the bottom, you can kind of see a graph of the dramatic increase we've seen over the years of those individuals with diabetes. So, what actually is diabetes? There's type 1 and type 2. Today, we'll be talking about type 2, but type 1 is the definition autoimmune beta cell destruction, usually leading to absolute insulin deficiency. So, basically, your body no longer produces insulin and it relies on insulin injections. Type 2, what we'll be talking about is the progressive loss of beta cell insulin secretion, frequently is insulin resistance. So the cell no longer is uptaking glucose. So looking at what classifies as diabetes, so prediabetes, what you're diagnosed with usually before, or if you begin testing early enough, is A1C of 5.7 to 6.4, fasting plasma glucose of 100 to 125, and fasting plasma glucose is having no food and only water for about 8 to 12 hours, and then a 2-hour glucose oral glucose tablet test, which is having a 75-gram glucose tablet, and then 2 hours after that measuring your glucose. And then as you see on the right side is the actual diabetes diagnosis, which is a A1C 6.5 and greater, fasting plasma glucose of 126 or greater, random plasma glucose of 200 or greater, and then the 2-hour plasma glucose over 200 and greater. Looking at who should be screened, or those individuals that are at a higher risk of developing this disease, are adults with a BMI 25 or greater, and then 23 or greater in Asian Americans, and at least one of the following risk factors: first degree relatives with this, history of cardiovascular disease, a low HDL below 35, or triglycerides over 250. If you're not too physically active throughout days, if you currently have hypertension, and then women with polycystic ovary syndrome, women with gestational diabetes should be tested lifelong, about every 3 years. Then all other patients in general should at least test at 35 and then go from there, and then all HIV patients as well. So what actually is a BMI, body mass index? It's a universal equation, kilograms divided by meters squared, which gives you a number, and then that bases your what classification of weight you fall into. So less than 18.5 is underweight, 18.5 to 24.9 is considered a healthy weight, 25 to 29.9 is overweight, and then over 30 is considered obesity. And then acanthosis nigricans is a kind of an indication, or an indication to go get tested for prediabetes. It's a skin pigmentation that you see with signs of insulin resistance, and some of the main parts are that you can see this skin discoloration are armpits, the groin, neck, inside of your arm or your elbow area. Then how actually being above a normal BMI or body mass index can increase your risk for diabetes. So having a higher body fat percentage does lead to an increase of inflammation, and this inflammation actually can lead to an increased risk of type 2 diabetes. So as you can see on the chart on the right, the overnutrition can lead to a lipid overload or fat overload and damages the mitochondria, leading to low-grade inflammation. And as I mentioned, this inflammation can lead to insulin resistance, leading to that diagnosis of prediabetes or diabetes. For those who are more interested in looking in depth at a cellular level on how this affects how a high BMI can increase your risk for diabetes, is that as white adipose tissues grow and you have that overnutrition, there is more mechanical and stress on the cell, and this stress on the cell results in immune cells being recruited to the area of where the adipose tissues are growing, which increases the number of M1 polarized macrophages. And then macrophages produce cytokines, interleukin 6 and tumor necrosis factor alpha to that site. So then from that, IL-6 and TNF-A inhibit insulin receptor substrate 1, as you can see in the chart to the right, or the graph to the right, and it leads to a decreased ability for glucose to be transported into the cell, which is where that insulin resistance comes from. So why exactly is this all important? It's because having prediabetes or diabetes can lead to numerous other health events. So having that high constant blood glucose or having type 2 diabetes can lead to numerous more health events, such as cancer, cardiovascular disease, stroke, sleep apnea, hypertension, hyperlipidemia, and in more serious cases, it can lead to damage, loss of vision, kidney disease or kidney failure, and then also increases just all-cause mortality. So the first place to start is lifestyle changes, just overall and general weight loss, and then trying to increase your physical activity and healthy eating. That is the always going to be first options whenever you're looking at prediabetes and diabetes. And then looking at pharmacologic agents, specifically the ones that have that higher percentage weight loss capacity. So one of the cheaper, most common ones is metformin. So metformin, it reduces hepatic glucose production and decreases your intestinal absorption of glucose. It does have a modest weight loss capacity, and then some adverse effects that you want to look out for with that will be diarrhea, nausea, and vomiting, dizziness, and hypoglycemia, as we can see with all diabetes medications, and lactic acidosis. It is one of the least costly medications, and then some contraindications to this medication are if you have allergic reaction to the medication, renal disease, or metabolic acidosis. And some clinical pearls is avoiding alcohol, as this can lead to increased risk for lactic acidosis. And then the extended release tablets can actually not be fully digested and broken down, and can be seen in the stool. And it's about all the clinical pearls. Looking at the next drug, SGLT2 inhibitors, so sodium glucose inhibitors. Mechanism of action on this is the sodium glucose co-transporter. So this reduces the amount of glucose that is reabsorbed into your body, so it increases the amount of glucose that is excreted via your urine. And this does have about a 5 to 10% weight loss capacity, and then some adverse effects with this are increased risk for UTIs, being that there's a large amount of glucose being excreted in your urine, increased thirst, hypotension, ketoacidosis, acute kidney injury, and increases bone fractures. This is a slightly more costly than metformin, but not the most expensive. And contraindications with this one are just hypersensitivity reactions, so any allergic reaction you have to beginning this medication. Clinical pearls are, this does have a significant or more significant weight loss capacity. It does have cardiovascular and congestive heart failure benefits, and it is a once daily tablet. And the diabetic medication that has the biggest capacity for weight loss is GLP-1 agonist, and the mechanism of action is they increase glucose-dependent insulin secretion from pancreatic beta cells, and along with the increase in the weight loss is it slows gastric emptying, so it makes you feel like you're more full for longer. And some adverse effects with this are nausea, vomiting, diarrhea, allergic reaction, medullary thyroid carcinoma, acute kidney injury, pancreatitis, and as I've mentioned with the others, hypoglycemia. This is the most expensive medication. Some contraindications with this are history or family history of medullary thyroid cancer or endocrine neoplasia syndrome. Some of the clinical pearls of this medication are, as I mentioned, the weight loss, cardiovascular risk reduction, and there are a few of these medications, specifically Trulicity and Ozempic, are once weekly injections. So if you don't know where to start by screening and knowing your risks. So going back to the slides on where I list those higher risk individuals, so physically inactive, family history of diabetes, and some of those others. Talk to your doctor or pharmacist and try to get tested to see where you stand with whether you have prediabetes or if you're lower on the scale. Improving eating and physical activity, and I would recommend not trying to go all out and change this all at once, because that's just setting yourself up to fail. So improving eating, if you eat out a lot, if you eat out every day at lunch for work, try bringing your lunch in twice a week and then slowly build from there, because you're going for the lifestyle change and not just a change that you're going to keep for about 3 weeks or so. And then physical activity, the same thing. Start by trying to walk 20 minutes twice a week at a local park or something, and then increase from there. But the main thing is you're looking for that lifestyle change that you can consistently go on for years, rather than something you're going to get burnt out on and end up not continuing a month in. Then questions, and here are my references.